Hotbed Talk.
Hello, I'm Steve Wooton, and I'd like to thank the organisers for inviting me here today to share with you my thoughts on the screening and assessment of nutritional state, or in simple terms, nutritional fitness. We think in prehabilitation in terms of physical fitness, and I'd like to extend that to consider nutritional fitness and, of course, psychological fitness. So what I'm going to do today is talk through what I mean by nutritionally fit or unfit and why it matters. I'll then talk through how we identify those most at risk in terms of screening and also in terms of assessment, and making it clear of the difference between the two. And then thirdly, how we use the screening and assessment to triage patients to care. There are many causes of a poor nutritional state, but at the heart, it comes down to two critical processes. The first is an inadequate consumption of food, where energy and nutrient intakes are insufficient to meet the demands of the individual. This results in a process known as reductive adaptation that ultimately leads to the physical or the phenotypic representation of that of the undernourished adult. As you can see here, we see major structural changes whereby lean and fat tissue have been lost. And these overt structural changes also indicate functional change. So along with the loss of lean and fat and other tissues, we see functional consequences. So that's the more classical, obvious view of undernourishment. The other approach, what we'd like you to consider, is that associated with infection and trauma and pathology or treatment. In other words, these are the stressors that act upon the body. These, independently of any other process, result in specific nutrient losses, which then underlie cellular damage and tissue malfunction. So even in individuals who haven't got overt weight loss, who don't appear frankly malnourished, they may still be nutritionally unfit. And that degree of nutritional unfitness will impact upon their response to their cancer and to their treatment. This is due to a loss of regulation and control at the cellular and subcellular level, making them physiologically and metabolically unfit. So nutritionally unfit are the processes that result in making you physiologically and metabolically unfit that relate to the availability of energy and nutrients within the body. How do we identify those who are nutritionally unfit? How do we find out who's most at risk? And then how do we triage patients so the right patients get the right care? For those who are overtly wasted, we don't need any special tests. So here is a classic presentation associated with advanced metastatic disease or advanced head and neck or upper GI cancers. We don't need special tests, it's self-evident, and we only have to do a physical examination to see it. However, we can also have, in the obesity-related cancers, patients who, despite their size and despite their high BMI, may themselves also be undernourished. So the qualitative expression of nutrition is masked by the excess adiposity. So we need an approach that allows us not only to identify those who've wasted or losing weight, but also those who have a constant weight. The other consideration are children. We use the same approach, but we use different tests, and that's beyond the purpose of this presentation. So I'm just going to park that for the moment. So the nutritional considerations are different. The approaches to assessing risk are similar. The tools we use may differ. Let's start with the most obvious one. That's weight history, their current weight and their weight loss. So weight loss, we think that about 40% of patients experience anorexia and weight loss prior to their diagnosis. So before they present, they're already undernourished. During treatment, be it surgery or chemo or radiotherapy, we know that the impact of these treatments will make their ability to eat and drink appropriately worse. So during treatment, 40 to 80% of patients will experience malnutrition during treatment. So in other words, it's expected for patients to be malnourished, and it's expected that that malnourishment may get worse with their treatment. And it's important to remember that even as little as a 6% weight loss predicts a reduced response to treatment, reduced survival, and a reduced quality of life. So weight loss is key. And of all the things we measure, weight loss is undoubtedly the biggest prognostic marker of a poor outcome. If we combine weight loss with the individual's current weight, or BMI, we can actually start to improve our prediction of risk. So the European Society of Enteral and Parenteral Nutrition, now known as European Society of Clinical Nutrition, published guidelines in 2017, where they considered both factors and used them to identify or score nutrition risk. So on the horizontal axis, we have body mass index, going from high to low. And as we go from high to low, we see an increasing risk factor. Similarly, we have weight loss on the vertical axis, going from low to high. And we can see as your weight loss increases, your risks increase. Taken together, the greatest risk is evident in those who have a low body mass index and have lost a profound amount of weight. What's important to recognise as well, however, is that even those with a high BMI, those who experience weight loss, have a high risk. So these two factors, before anything else, are probably our most significant prognostic indicators of risk. But over the last 10 years or so now, we've realised that body composition is increasingly important. So weight is key, yes, but it's not sufficient to adequately explain the differences we see in risk. What does explain those differences is the lean mass that the individual possesses. And the problem for us is that many patients may have a normal weight or even a high weight, so their BMI is normal or high, but they are actually lacking in lean tissue, muscle in particular. And that lack of muscle is masked by the presence of excess fat, what we use the term sarcopenic obese to describe these individuals. And as you can see here in the figure on the right, Prado demonstrated that if you compare survival curves in cancer patients of a normal weight and body composition, the upper line, with those of a normal weight but sarcopenic obese, you can see that the sarcopenic obese have something like half the time to death than those of a normal weight and body composition. So lots of different approaches are available to us to measure muscle mass. And in particular, one of the favourite techniques in research is image analysis. But it's important to recognise that these measure different things. So if we start with magnetic resonance imaging, it's probably the gold standard for imaging techniques. It measures all of the muscles, and with 3D stoichiometric analysis, you can actually pick up different tissues of different volumes. DEXA, using X-rays in the the two-dimensional coronal plane, will give us visible muscle area. So this is largely the muscle of the appendicular mass, so legs and arms. It's not a gold standard by any imagination, but what it is a reasonably accessible marker. Similarly, routine CTs analysed using cross-sectional area mapping, such as using Slice-O-Matic, can allow us to describe the cross-sectional area of different tissues within an abdominal slice, for example, obtained in routine planning or staging CTs. These also mark muscle mass, but they don't measure muscle mass. They only measure muscle mass in the plane of view. Unlike DEXA, which is mainly looking at legs, CT is mainly looking at the abdomen, clearly measuring different things. In intensive care, there's been a lot of interest in using ultrasound to measure the depth of muscle. Again, in a two-dimensional plane, sagittal plane, again different from that seen in the abdominal CT or the whole body coronal DEXA. Again, a useful marker of muscle mass, but not a measure of muscle mass. So what we've been looking for are different ways of measuring muscle mass that aren't research tools that can be used in clinic. So we've been doing a lot of work around bioelectrical impedance analysis, because it's a point of care real-time measure that we can use, which is now, in this instance, using segmental multi-frequency impedance analysis, has been shown to be highly correlated with whole body MRI. So we can use these techniques to obtain measures of muscle, lean mass and fat mass, but we can also get a qualitative measure, and that's the phase angle. And the phase angle is simply the product of the resistance and the reactance at different frequencies. What it gives us is a very powerful prognostic marker of survival in advanced cancer, as shown here in the research from Gupta. This is the survival curves for a group of colorectal cancer patients with advanced cancer, showing the upper line is for those with a phase angle above the mean, and the dotted line is those with a phase angle below the mean. And again, you can see that the survival times of the low phase angle is something like a third of that exhibited in those with a higher phase angle. So we can use these technologies to measure body composition and to provide additional information around the quality or physiological state of the individual. Others have started to combine these measures. So here is some work from Lisa Martin, where she's taken sarcopenia and low muscle attenuation from CT scans and combined them with weight loss. Each of them have a powerful effect on survival, as shown in these survival curves, but the greatest risk is seen in those with all three features. And what's notable in this data set is this is in overweight and obese patients, not in patients who already show overt wasting. And patients with the features of low lean and poor quality muscle and weight loss survive less than a third of those who have no features at presentation. One of the other very readily accessible markers of risk are what we refer to as the nutritional dietary impact factors or symptoms. And I've listed them here, and they're all the obvious conditions which present during either the cancer or its treatment. And most of them are evident in chemo and in radiotherapy and in biologics. Fatigue, nausea and vomiting, taste alterations, smell alterations, mucositis in the mouth, diarrhea, constipation, dry mouth, anorexia, satiation on eating, largely due to pain on eating, dysphagia and swallow, strictures and obstruction. All of these we know are associated with cancer and its treatment, and all of these impact on the patient's ability to eat and drink, and therefore their nutritional state. And if we look at those with a large number of these dietary or nutritional impact factors and those who have none, we can see a huge increase in the number of patients who are malnourished in this data from Ice and Ring. So these patients who have 5 or more symptoms are nearly all of which are likely to be malnourished, in contrast to less than 1 in 8 of patients without any of these features. So we have weight loss, we have body composition, we have intake, we have appetite, and we have these dietary impact factors. And the question is how can we bring these together to enable us to identify nutritional risk? Well, there are 3 types or 3 approaches: screening, assessment, and diagnosis. In terms of screening, we can bring them together to form a quick, simple tool that anyone can use. You don't necessarily need to be highly trained or access specific tests. And this allows us to find and identify those who are at risk of being malnourished. It doesn't diagnose malnourishment, it's risk, and to direct them to others for care. Assessment is a more detailed analysis. It generally requires higher degrees of training. And again, it can confirm the risk or the presence of undernutrition and direct patients for treatment. And in both cases, it's really important to link the measurement with the action. The final category is diagnosis, and this is largely specialist. It requires, like any diagnosis, to take a history, to do a physical examination, and then call on special tests, for example, body composition or micronutrient status, to not only identify those who are malnourished, but to give clues to the likely cause of that malnourishment. In other words, to diagnose and then treat. So I'm just going to go through some of the tools we can use to screen, assess, and diagnose. The first is the one that people are probably most familiar with, and that is the Malnutrition Universal Screening Tool, which has now been effectively mandated across the NHS in and outpatient settings. And this relies on the body mass index as an indicator of current weight, weight loss, and then an acute disease effect score, which basically picks up those who are likely not to have eaten or unlikely to eat for 5 days or more. Combining these, it's possible to come up with 3 categories: low, medium, and high risk. The threshold is very low, so there are chances of finding false positives, but you're less likely to get a false negative. The important thing is, having identified those at risk, is to refer on where necessary for treatment, to observe if they're borderline, and to constitute routine care if they're otherwise well-nourished, low risk. The perioperative community have gone one step further and added albumin to the must score and replaced the acute disease score with have you been eating less than half of your normal diet in the preceding week. And this too can be used as a nutrition score that captures risk and triages patients to care. It's important to recognise that the albumin is not a nutritional marker. It's a marker of surgical risk. And very often patients who are profoundly malnourished can have a normal albumin, and it's also possible for those with a low albumin to be normally nourished, and if you intervene, for albumin not to change. So again, another score been associated with increased risk to identify those most at risk and nutritionally unfit. But jumping from a screening tool to a diagnostic tool, the European Society of Clinical Nutrition have worked together with our American, Australasian and Asian colleagues to come up with a diagnostic criteria using both the phenotype and the etiology. Again, it uses weight loss and BMI, but it extends that to include a measure of body composition in terms of muscle mass. And etiologically, the acute disease score or low food intake is captured in order to identify those most at risk. And the diagnosis of malnutrition requires at least one of the phenotypic criteria and one of the etiological. So it's possible to have a normal weight, but to be eating poorly and have a low muscle mass to be considered malnourished. The tool that's attracting greatest attention in cancer at the moment, and the one that we would commend for prehabilitation studies or services, is the patient-generated subjective global assessment tool as developed by Faith Ottery. And this has 2 components, one completed or generated by the patient, and the other which is a health professional assessment. So in the patient-generated box, we have weight history, BMI and weight loss. We have the dietary impact factors, and we have whether the patient is eating normally or not, and whether they're showing functional fatigue. Taken together, these can be used as what's known as the short form SGA and can be used to characterise risk in the patients. It can be improved, however, by combining those patient-reported data with that of a health professional who's trained to make the appropriate assessments. In other words, you're looking at the diagnosis and the age of the patient, the extent to which there are metabolic stresses, cachexia for example, that are evident, and it also includes, most importantly, a physical examination, looking for signs of lean tissue loss in particular. When combined with the patient-generated components, you can now generate what's known as a scored subjective global assessment. Together, these techniques allow us to identify those who are well nourished, those who have moderate malnutrition or the risk of becoming malnourished, or those with severe or overt malnutrition. And like any good tool, it leads to action in terms of a nutritional triage, in terms of eating guidance, giving advice, symptom management, and where necessary, nutritional support with oral or artificial nutrition. And what Ottery and colleagues have shown is that the score or the category generated by the SGA is associated with mortality, post-operative complications, length of stay, overall survival, and increased hospital costs. So what I've done here is combine the 5 tools and indicated the items in each tool. And what you can see is that there's a commonality between the different tools. They basically are very similar with some slight changes. The MUST, the PONS and the short form PG-SGA are all screening tools. And in particular in oncology, I would commend the PG-SGA short form because you're just simply asking the patient 4 questions from which you can generate a risk score. If you're going to go to assessment, then I would use the scored PG-SGA or the GLIM, but the GLIM really is a diagnostic tool. What is important is having somebody who can make a nutritional diagnosis available on the team. And the most obvious person in that category will be a dietitian or a physician trained in clinical nutrition. From the dietitian's perspective, they will carry terms of a full nutritional assessment, including eating histories and the use or misuse of dietary supplements. They'll look at those dietary impact factors and ask themselves about the extent to which they are contributing to the poor eating and drinking, but they'll also take into account any anxieties associated with eating and drinking, their innate beliefs, their culture or their faith. They'll address the issues raised by referral to web-based advice, the so-called Dr. Google effect. They'll explore the comorbidities which may be evident, particularly in older patients, coexisting with their cancer, which may in themselves require dietary interventions. And they'll seek to educate the patient because very often poor education around nutrition contributes to poor nutrition. And obviously socioeconomic status is important there too. What I'd like you to note particularly is that this is a cumulative experience across the patient journey. It's not sufficient to make these measures once, for example, prior to the treatment period, but really what we should be doing is screening and assessing our patients throughout the experience, preferably from the outset at diagnosis, through treatment, through into convalescence, and then later into maintenance or survival. So in other words, 1, identify the risk. 2, optimize the patient throughout their journey, not just in one specific component, for example, ERAS during treatment. And then to maintain, wherever possible, and ideally improve their nutritional fitness through your nutritional interventions. When we engaged in the Macmillan Royal College of Anaesthetists and NIHR Cancer and Nutrition Collaboration Review, we recognised the importance of the the NHS England's approach to personalised care. So with increasing risk, we need to increase the level of care that's offered to the patient. At the bottom of the pyramid is universal care. So these are individuals with the lowest risk or no risk of undernourishment, in which we'll be looking largely at using advice and providing supportive self-care. This is largely home-based and ideally used via remote services such as the web, apps or phone. However, once screened, a patient who's considered at risk would then move through into assessment, where their needs would be identified and targeted care would now need to be introduced. This is usually linked to dietetic counselling, with or without the use of oral nutrition supplementation, maybe diet first, food first, or it may include the use of specialised feeds. And they would specifically address the dietary impact factors. What is it that's preventing the patient from being able to eat or drink? Such approaches are largely outpatient or community-based. However, once again, these may be insufficient to meet the needs of the patient who has complex needs. We may then move to artificial nutrition support, where we probably would involve a nutrition support team or an intestinal failure team. These may well be hospital-based inpatients and may well require the use of either tube or vein feeding. What's important is that the screening and assessment tools are used to identify what level of care the patient starts with at presentation. And similarly, they should be used throughout the care to either up, regulate or down regulate the level of care in response to the patient's needs. I'd like to stress that dietetic counselling is the key to good nutritional care. It's more than just simply measuring the diet. It's very much about addressing the dietary impact factors and knowing how and when to use oral nutrition supplements. It's very much about understanding the needs of the patient and helping them understand what it is that they need to do. So it's a very enabling process to improve the confidence in the patient to make the changes or follow the dietary advice or therapeutic interventions that are being proposed. It's not enough just to give patients a leaflet. What we find now is that it's much more important to work with the patient, either individually or collectively, for example, in small groups led by a dietitian, whereby they can explore together their concerns and their approaches to improving their nutritional well-being. In the face of COVID, we have to move more remotely, so there's a lot of interest now in the use of apps and the web to provide remote coaching to inpatients so that they can better improve their nutritional well-being when they cannot attend outpatient clinics. And clearly the dietitian is the important link between food-first approaches, the use of oral nutrition supplements, before moving to artificial nutrition, feeding via the tube or a vein. What we know is that if we triage patients appropriately, we use oral nutrition support, we can improve outcomes. My colleagues Rebecca Stratton and Maren Osilia spent most of their professional career demonstrating the importance of this approach. And through a whole series of systematic reviews, meta-analyses, health economic analyses, they were able to demonstrate that appropriate triaging of patients and into appropriate care leads to lower mortality, fewer post-operative complications, shorter length of stay, an earlier return of GI function, a lower rate of reoperations or readmissions, improving gut integrity and reducing permeability, improving wound healing, and because of triage, actually being able to use less PN by actually making sure that patients were fed via an EM route first, and overall reductions in hospital costs. We also now have increasing amounts of evidence showing that nutrition within multimodal prehabilitation programs can also improve outcomes. I'm indebted to my colleague Chelsea Gillis, who's recently published the evidence to date of nutrition within multimodal prehab versus nutrition only, and has been able to demonstrate that appropriately triaged and supported patients can achieve a 2-day reduction in terms of their length of stay in this particular meta-analysis. Admittedly, there isn't a large amount of evidence, it's accumulating, but it's certainly consistent with the evidence that we see for preoperative nutrition, which would make sense. So to conclude, my take-homes are quite simple. Being nutritionally unfit matters, therefore we should identify those most at risk. For screening, we should consider going beyond just simply doing a MUST score or even a PONS score, and I would recommend the use of the short form patient-generated subjective global assessment, PGSGA. For assessment, Where a trained individual can conduct a physical examination, we would recommend the scored PGA, PGSGA, and for diagnosis, that really does require somebody who either has specific training in clinical nutrition or a dietitian to conduct an appropriate history, physical examination, and then call on the special tests, as you would in any other diagnostic process, either, for example, the measurement of body composition or the use of micronutrient assays. So the approach such as expounded by the European Society of Clinical Nutrition, the GLIM, or a dietetic-led assessment and diagnosis is key. Remember, what we're trying to do is triage patients to care, be it universal, targeted, or specialist care. And we know that nutritional interventions can improve outcomes. So the earlier we can triage our patients and direct them to care, the better. I'd like to give special thanks to my colleagues across the National Institutes of Health Research Cancer and Nutrition Collaboration, and also my thanks to the Macmillan Cancer Care and the Royal College of Anaesthetists in working together in the Macmillan Review of Prehabilitation Guidance, and my colleagues across the Nutrition Support Expert Group. And I'd also like to acknowledge my colleagues at Southampton from the clinical nutrition teams, the nutrition support team, intestinal failure unit, my dietetic colleagues, and of course my colleagues in Southampton in prehabilitation and perioperative medicine.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.